My name is Domenico Rutigliano. I'm a software engineer. I've been living in Australia for the past 11 years. Together with my good friend Daniele Mastrorillo, which is also a software engineer, we've been working on an app to help Australians to find easily information about the COVID-19 disease and the SARS-CoV-2 virus, and to spread awareness about the issue of the virus, because we do have understood through social media that there is a lot of misinformation out there. There is a lot of people thinking that it's a normal flu, and there are people that are not even looking at the events that are afflicting America and Italy specifically in this case, that touch us personally, considering that we have most of our relatives there, and we may not see them anymore, not even be able to grieve on a grave or a corpse, because Italy at the moment is coping with a massive amount of people dying altogether due lack of information as well in Italy. So we are doing this because of a sense of social responsibility. So I'm not enjoying to spend my free time on the computer with Daniel to code something, because that's what we do during our daytime job. The reason why we're putting so much effort is that because we do feel that every one of us that has skills that can help with data and giving this information to the public is something that we should do on not just gathering information that we get from the mainstream media, but directly call experts like virologists and medical staff and doctors and nurses to find out on the field what's going on and what can be done to help, what we can do to help. So let me introduce the Associate Professor Timothy Newsome, Associate Professor of School of Life and Environmental Science from the Sydney University. All right, Tim. So as we agreed, we're going to record this now, and sure. We're going to go through the questions. But before that, can you please explain us who you are and what you do for a living?
Yeah, sure. Okay, so I'm Associate Professor at the University of Sydney. I lecture in virology to third-year students, and I run a research lab. My research area is basically basic virology. I do the cell biology of viral infection, and my particular focus is the vaccine to smallpox.
Oh, perfect. So it's really interesting because we do have a question about vaccinations. So
good.
Yeah. So we have been reading news about what's going on overseas, and there is an article about the CDC, the American CDC, that has been testing the COVID-19, the SARS-CoV-2 presence in the cabins, and the 17 days from the last passenger leaving the cruise, the ship, there was still presence of the virus on board. So is it like that persistent? And if someone infected comes to our place, and of course we don't know about it because maybe he may not have symptoms, and coughs around or spreads the virus in our household, is that going to be as persistent as is in this ship, or what happened there is a peculiar case or something that will not happen to our home?
Yeah, so there's lots to tease apart in that. Maybe I'll just touch on that last point first while it's on my mind before I address some of the other questions you're raising. So there's lots of complexities here and there's lots of unknowns, and that's a caveat to everything we're going to be speaking about because it's such a new discovery. But I think and I'm not sure whether you're making the same mistake but it's certainly made in the media a lot about confusing the period between when you're infected to when you show symptoms and a period of when you're potentially infectious and asymptomatic. So, you might be infected on day 1 and you might show symptoms on day 5 to 7. That doesn't mean that you're infectious that whole period. There may be a period of 24, maximum 48 hours before you show symptoms when you might be infectious. But there's no evidence, and you wouldn't expect people to be infectious that whole time. Okay, so the window of between not showing symptoms is different from the window of being asymptomatic and potentially infectious. Do you understand what I'm saying?
Yeah, of course. Yeah. We just listening to.
And I'm maybe you understand that, but that distinction is not not necessarily made in the media so much.
Yeah, no, it hasn't been very clear. People start to think that you can be infectious all 14 days.
Yeah, exactly, and there's no evidence for that, and it's certainly not true. How long that period is, and that's also true for flu virus. I mean, when people have done, there were some interesting studies where people infected volunteers with influenza virus and looked at virus shedding over symptoms, and they could see that there was a period of time before you showed symptoms where you were shedding virus. And, so that's detecting virus, it's shedding virus, it's not necessarily being able to infect other people, but you're certainly shedding virus, so it's quite likely to be infectious to other people.
Okay.
So that's not unusual, but how long that time is, maybe 48 hours in the case of coronavirus. That's what we're thinking. As I said, everything I say is a caveat that we may learn more and refine some of what I'm saying.
Because it's a complete novel coronavirus, so no one knows anything about it.
Exactly, but so I just wanted to make that distinction.
Yeah.
In terms of detecting, I'd have to know what the test is the CDC did. So this virus is what we call an RNA virus. So the genome of the virus is not DNA like our cells, it's RNA. It's a different type of nucleic acids. So you can detect the virus using an assay to detect this RNA of the virus. And that's how people are diagnosed at the moment. The current diagnostic techniques are detecting the viral RNA. Okay? And this technique is very sensitive. And very selective, so it's clearly a positive. When it's conducted properly, it's quite a robust assay. Okay, but that doesn't mean that the virus is infectious or viable in that sample. So someone, for example, who has completely recovered from an infection can still have viral RNA present in their lungs. It can take a while because the assay is so sensitive that you can detect viral RNA in places where there's absolutely no viable virus that could infect anything.
And that is because the virus, in order to be infectious, needs the RNA to be encapsulated into the so-called corona, right? That has the reception.
Yeah, exactly. I mean, it's like you've got a functioning car and you split it up into its components. It's no longer functioning when you've broken it up.
If the RNA is missing, the key to get into the cell is completely inactive.
Yeah, exactly. It's just going to be completely not viable. But the RNA can stick around for a long time. But so you can detect it, and that might be useful to show that there was somebody on the cruise ship with coronavirus, or somebody really had a coronavirus infection. But it's not an indication of a potential hazard. It could be an indication of a hazard, but it is not necessarily an indication of a hazard. Okay, we are developing other tests now. I mean, the problem with the test now, the test is great. You can see whether someone has the coronavirus, but what this test can't tell you is whether someone's been exposed. So if someone has recovered, this test is useless. You can't distinguish someone who's naive and someone who has recovered with this test, because it's only detecting the actual virus. So there are other tests, what we call serological tests, which detect antibodies against the virus, and they're being developed now. They should be available fairly soon, but that will be critical, because if there are asymptomatic people out there who have recovered and might be immune, but we don't know about them, this test would be able to identify those.
Okay.
That's really...
So I guess the thing to get from this is that, A, you're not going to be infectious the entire 14-day period that you're in incubation, and B is that even if there is presence of the virus on a surface, it doesn't necessarily mean that it's infectious.
Yeah, let me just not say virus, but actual viral RNA, because that's what the TSA is for. It's for viral RNA. So there can be viral RNA present around without it being infectious.
And that is due by the fact that the virus, once on the surface, it won't last what
the
contains...
virus has a half-life. Yes,
Yeah,
and it won't be viable for an extended period of
it
time.
will break down, and then you can find the
And
RNA.
different viruses have very drastically different viabilities and half-lives. There's some, HIV, if it's not at 37 degrees in blood, it doesn't last more than, minutes. Foot and mouth disease can last in the soil for years and has blown from England across the English Channel into France and infected cattle.
Incredible,
So viruses drastically differ in their robustness, in their resilience.
So say it so, right? So the next question would be...
I'll just come back to one more thing.
Yeah, sure.
Even if that's one way of detecting virus is this kit, which is effectively this diagnostic kit we're using now, and you use that to detect it in patients, and we also use it before we release patients when they get a negative result. If you can't detect viral RNA, then that patient is safe to go back and not self-isolate anymore. So we use it to detect it, and also as a criteria for releasing a patient who's recovered from coronavirus. So there's other tests where you can actually test for viable virus, so these look for different things. These look for the ability of the virus to infect cells. So you'll take a sample from the environment and you'll add that to cells in culture, and you'll see whether those cells become infected. So that's a different assay. So as I said, I don't know what the CDC did. I presume it was an assay for RNA, but there are other assays which can be used, and these assays have been used to determine the half-life of coronavirus on various surfaces. And there's a paper just being published looking at how long coronavirus is viable on plastic, stainless steel, copper, cardboard, and this kind of stuff.
Yeah, there have been many infographics going around on social media about that. That's like how long the virus lasts on surfaces. And
and the upshot from that is that it's probably on something like stainless steel a couple of days or something like that.
Being active a couple of days on stainless steel, right?
Yeah, a couple of days is something.
Is that the material where the virus sticks on that kind of gives an environment to preserve it itself? Maybe because the stainless steel has...
I think it's more about environments which, one, are not toxic to the virus. So like copper, it only lasted, I think, 3 or 4 hours on copper.
Okay.
There wasn't much difference between stainless steel and plastic. Cardboard, it was fairly porous. So you can also think about how easy these surfaces are to clean.
Yeah.
And you can also think about something that's porous will drag the virus away from the surface, so maybe it's less easy to then infect somebody else. And it's also important to point out that just because there's another caveat, that just because something can infect cells in culture and be positive in this assay, it might not be what we call a sufficient infectious dose to really infect people.
Okay.
Humans, we have our own mechanisms against viral infection, and many viruses, you need, tens of virus particles, 50 virus particles, thousands of virus particles before it moves into the realm of actually being infectious in a real life situation.
So it's not
rather than just being able to grow in cells.
Yeah, so it's not as straightforward as if the virus is on a substance you're going to get, or on a surface you're going to get it. A lot of it goes into play in how much of the virus is on that surface, what the half-life is of it, and
exactly, yeah. So how is it transferred? How is the surface clean? Are you really getting enough of it for it to be infectious? Because if you could see viruses, you would see them on everything. Our bodies, our surfaces are teeming with viruses, but getting sick is still relatively rare. So, so most viruses, you need a pretty hefty dose in order to actually get sick and overwhelm your body's defenses.
Yeah, because most likely what happens when the virus gets inside us, like through the orifice, mouth, nose, or eyes, whatever, it will take like a certain amount that will survive the immune system. The immune system will recognize it.
So there's an adaptive immune response. So you don't have an adaptive immune response when something's new, but you have defenses like, Mucus degrades viruses. Mucus is antiviral. The
pH,
saliva is antibacterial.
Yeah.
We have lots of defenses which are very effective.
Yeah.
So just because you can detect cells in culture and say, oh yeah, there is some viable virus, it doesn't mean it's a true hazard to humans.
Okay.
I would classify that as generally very low risk unless someone with coronavirus has coughed on the banana or something like that. So that's why we generally think that in most cases it's sustained close contact with someone who's sick. So I think the PM gave good advice. One of the clear messages he's given, which haven't been few and far between, was, he said, 15 minutes if you're in the same, what do you say, 15 minutes if you're close to someone, 2 hours in the same room. Now we're talking 95% confidence intervals, so, what's hard for the public to dissect is this kind of high risk versus low risk.
And
you leave the house, you're at risk.
Yeah,
but most of it's low risk. Most of the transmission events that we've seen are close contact over an extended period of time.
So, but again, right? It really also gets down to the sensitivity that each individual has about this and the awareness of what to do, what not to do. I guess if someone goes around, even a supermarket, touch things around, they keeps putting the hands in his mouth, he's going to collect more and more and more virus, and then we get that threshold that will actually.
But also, if you're in an environment where things are getting sun on them, this kind of stuff, the virus won't really survive. It's not like it's just constantly accumulating till it gets to a high level. So, I think that's why the messaging, it should be, and most of the time is. It's not like I need to put myself in an environment where I can't get sick, because otherwise you just go live in the desert. The message is, you reduce your risk, and reduce your risk means, don't take 2 trips to the supermarket, take 1. Don't socialise, don't stay at home if you can, wash your hands as much as possible, keep distance away from people. If you're sick, don't interact with anybody. If you're sick, don't go to work and package shelves in the supermarket. Don't, if you can make an easy choice not to handle money, don't do it. All these things reduce risk. This is the easiest message.
This takes us to the next question, because the thing we have seen happening a lot overseas, like South Korea, China, even Italy, is people going around the streets, sterilizing everything with sprays. So spraying aerosol in public transport, to sterilize surfaces. Is that a concern, considering we are not doing that? Is that a concern that maybe the virus can, let's say, people could spit on the floor and do any nasty thing, like urine and feces are a vector for the virus? Is that a concern about walking on the street, coming home and having the virus on your shoes?
Look, I think it's a risk. I think it's low risk. I mean, if you have Italian background, I think it's fairly standard in European countries, because my wife is Greek, is that you normally take your shoes off when you enter your house anyway. So, it's not like I walk around at home with my shoes on anyway. But again, I think it's a risk. I don't really know about this sanitizing the streets. That didn't make a lot of sense to me intuitively. Maybe there's something I don't know about that. Okay. I know in the hospitals in the UK, I was listening to a podcast from a doctor who said that there's someone going around just wiping door handles all the time and lift buttons. I think that makes more sense.
That makes
People
sense,
touching their faces and depositing that, where hands are going, to me, seem like high risk. The streets, look, I mean, intuitively that didn't make sense to me. Maybe I could look into it a bit more, and there's actually a good justification for it. But I thought that more like
because we've seen
a bit of a show more than anything.
Okay.
When I go shopping, I'm not taking any precautions. But look, if there's an avocado, which I know people have been handling, maybe I'll give it a bit of a wash in soapy water. Or an apple, I'm going to give my daughter, maybe I'll give it a little wash first before I give it to her.
Okay.
Other vegetables are going to be cooked and stuff.
Cooked, that's correct.
Yeah, you can do much more by learning to not touch your hands, washing your hands, not touching your face and washing.
Don't touch. Which is incredibly hard, because there are experiments that have been done. Like a person on average touch his face 16 times per minute.
I think I've just touched my face 3 times.
Very hard.
Yeah, right. As soon as you don't touch your face, I feel like touching it.
Yeah. So I think the only thing that has really concerned me, besides the close sustained contact being an important route of transmission, is what happened on the cruise ship of Japan. I mean, what seems to have happened there is that, and it's not for certain yet, but they suspect that some of the staff were infected, and then they were kind of contaminating the food before it got to all the cabins. Now, the cruise ship is a strange environment. It's quite close.
It's a bit like airplanes. I heard that at Virgin Australia and Tiger, they had personnel infected, and they kept that secret for I think just a economical reason. And then they've been like a little bit dodgy about that. But catching the plane.
I haven't followed the airlines, but certainly in the cruise ship, you've got a semi-enclosed environment. Yeah. I mean, the disaster was they put everybody in quarantine, and if they still had staff who were COVID,
helping
preparing the food,
then
it was just a little incubator. I mean, so that's a kind of exception to the rule of just keep apart from people and close sustained contact, because those passengers wouldn't have had any choice about that. So that's certainly very concerning. But I think given that the measures that have been successful in countries, I mean, in China and in South Korea, it's not like people are not getting food delivered. It's not like people are not going shopping, and yet the transmission rate has drastically dropped. So I think, our major concern, to just, as I've said over and over again, is sustain close contact with people.
Well, the social interaction in China changed a lot. People learned how to not shake hands. I've seen like people touching their feet just for like a form of greeting. The culture changed.
But I guess what I'm saying is that if every door handle immediately infected 20 other people, it wouldn't have worked in China, whereas it did, which tells us that the transmission mostly is via aerosol and hot human-to-human contact.
Okay.
And on that note, Tim, obviously the elections, and we're expected to vote coming up shortly. I think it's on the 28th.
Sorry, I don't keep up with politics. Which election is this?
I'm not sure. The Electoral Commission here, on the 28th of March, I think there was a sponsored ad that came up on my newsfeed in regards to us going to vote. So I don't know if it's a local one or if I haven't been keeping up to it either. But on that note of social distancing and stuff like that, I mean, first of all, are the election booths that you see at every election, are they going to be a vector of transmission? Is someone that's going to go voting, even if they're carrying their own pen or carrying their own whatever it may be, if they cough on a booth and then 100 other people go and use that same booth, is that going to be a potential risk there, as well as the social distancing that's going to be a bit...
Look, I mean, you can talk about the booth, but I would just be against any kind of gathering that you see where people line up to vote. I mean, those areas are crowded. I mean, they do it in schools. You have, at least 100 or so people inside that room, and I can't see it working at all. I mean, the lines are long enough if you had to try and keep 2 or 3 people in those rooms. So I think the whole process would be fundamentally flawed in the current environment, not just the election booths.
Yeah, and the same thing happened when in a Sunday night the government announced about the help for people that are facing difficulties with economical difficulties, and then so many people lined up.
This is disastrous.
And so you see these long lines at Centrelink of people without, just do not having that social distance. So it is a bit scary when that. That are fails for me in the system that increase the community spread. The election is.
That would just seem to be ridiculous if they went ahead with that. I mean, I understand there's probably people who are not internet savvy who would struggle with voting online, and we completely screwed it up last time we tried to do it, if I remember correctly. Hopefully that was a learning experience and they would be able to implement it, but there's also postal voting, so that would seem to be something that would be a no-brainer to implement.
Now, Tim, on that note as well, everyone's obviously saying that 1.5 meter distancing. Now, are there circumstances where that virus can travel more than 1.5 meters, or are we fairly safe at a 1.5?
Again, it's about risk. So, I mean, I don't know what the evidence for this 1.5 meters is, but it's basically thought that when you cough or something, it's the larger respiratory droplets which can carry the most virus and therefore the highest risk for transmission. So, and they tend to sediment at a distance of about 1.5 meters. Of course, the problem is, he also said 4 meters squared, and if you work out what 4 meters squared is, it's about 1 meter radius. So again, this is a problem with the Prime Minister's messaging on this particular aspect.
Yeah, of course. That's what, like, people like us, which are analytical, and then we hear these things like incongruence in the messages. We just freak out, like, these people don't know what they're talking about.
Look, I have all friends and colleagues asking me, should I send my kid to school, because the messaging is so unclear about this.
I would not, honestly, I would not.
No, we're at daycare still at this stage. We're not quite at school, but we're pulling our kids out of daycare. But I don't know what someone would be expected to believe based on what he said. It's safe, but you should take your kids out if you can.
Especially because of the fact, right? That's a factual thing.
Getting back to that 1.5 meter thing. So basically, it's the heavier
kids. They keep touching their faces. Kids, they keep touching. You cannot tell kids don't touch your face. They touch everything, and I think that we published on COVID-19.com, COVID-19downunder.com. We published a video of an American YouTuber that went in school and they put like phosphorescent powder on the hands of the kids. Just 2 kids in a class of 30, and after an hour, he went with a black light, and that powder was everywhere.
Yeah, we do a similar thing in our undergraduate classes. We use glitter and do the same thing, and I
cannot be like
stop thinking about the virus. There seems to be some indication that children are not just less susceptible to disease; they may actually be less susceptible to infection. That's still too preliminary to really draw thorough conclusions, but I guess that would be some argument that our schools aren't as bad an environment as they could be.
Okay.
Now, we've also heard stories, obviously... It's
so just to finish off that 1.5 meter, there are definitely smaller droplets carrying virus going at a wider thing. So if you're in an enclosed space that's still, further than 1.5 meters, they could accumulate and I think you'd be at higher risk. So, there's no black and white line at 1.5 meters. It's just the larger droplets, which are higher risk, will tend to sediment by gravitation over that distance.
So the 1.5 meters hasn't been studied for COVID-19 specifically?
It may have been. I'm not sure. I doubt it's been studied for this particular virus because, again, things are so new. So it's probably based on literature. But I haven't looked at that literature.
It's sounding more like a rule of thumb, though, that your heavier, obviously, droplets are going to roughly, on average, land 1.5 meters away. But
in science, like when we give number,
we can base it on, there are human coronaviruses, right, that contribute to the common cold. So I'm just guessing here, but it could be based on studies with flu or studies with human coronavirus.
Yeah, and my point is, like, usually when in science a number is thrown up, it has a tolerance. So 1.5 could be like the peak of a Gauss bell.
Exactly. We're talking about 95% confidence intervals.
So it might be like plus and less 5%.
Based on that.
Yeah, plus and less 5%, right, on the value.
Yeah, exactly. Yeah.
So say it so, right? So there was like a lot of discussion with our followers on Facebook about the fact that in Australia it won't be as bad as other countries because our climate is hotter, and then this will stop the virus to spread. Is that like something that would has a scientific base, or is just a rumor that people come with without real thinking about what they're saying?
Well, one, there's very different climates in Australia. So I'm not sure I would agree with that. As a generalisation, we simply don't know yet. We simply don't know. So a huge question. I think that the two biggest questions that need to be addressed, one, is it seasonal? So human coronaviruses are seasonal. They, as I said, they contribute to the common cold, but we don't know whether this virus is seasonal. So that's a big question. We're heading into flu season, to flu season now. So is that going to make? And whereas the northern hemisphere is heading out, so is that going to make the problem much worse for us? Maybe, maybe not. We just don't know. Okay. The other big question is, what kind of resistance do you have after you've been infected?
Oh, okay, so that's talking more about if you've already been infected, are you going to be immune potentially another time you get infected?
Yeah, and are you going to be immune at all? Are you going to have weak immunity? Are you going to have short-term immunity? Are you going to have long-term immunity? We have no idea.
For the same reason we catch influenza every year, potentially.
So that's a slightly different thing, is that influenza virus mutates. So as it mutates over year to year, it changes sufficiently that you can be infected by the descendants of strains you have prior immunity to. So it mutates, it changes, that it's now sufficiently different that it can escape your immune system.
Okay.
So that's kind of the reason why influenza. Now, human coronaviruses just don't induce very good immunity. They're not, so you can get infected them by them again, and the immunity is quite short term. So we just don't know. There's some other RNA viruses like measles and mumps. You get infected once, you pretty much have lifelong immunity. There's other viruses which just don't induce very good immunity. So that's a huge question. I mean, I would hope at least that if you were able to be infected again, you might show reduced symptoms.
So what does that mean for us in the sense of a vaccine? Is that something possible within the next 12 months? Is it something likely, or is there no chance of a vaccine being released at all?
Yeah, so getting back to that point, is that if a virus doesn't induce good immunity, then that doesn't bode well for a vaccine. It doesn't necessarily mean there can't be a vaccine, but I would say that's not a good indication. But again, we don't know. The very early data coming out suggesting that people who are infected produce good antibodies against the virus and maybe neutralizing. So that's a glimmer of hope on that direction, that that there might be at least short-term, perhaps long-term immunity. That's very new data now. Your question about a vaccine. Okay, so if this was an influenza pandemic, we would have a vaccine guaranteed in 6 months or less. We have a pipeline. We can make a vaccine against pretty much any new flu strain. We also have
rotavirus, right? It's a rotavirus. The flu virus is called rotavirus.
No, rotavirus is a gastrointestinal virus.
Okay.
Diarrhea. It's a different family to
Okay.
influenza virus. So we have a pipeline. We make new vaccines against the flu every 6 months for the northern and southern hemisphere, right? If there's a new pandemic, it would do damage, but we would have a vaccine guaranteed pretty much 99% within 4 to 6 months. We also can stockpile antivirals, because we have stockpiled antivirals that are good and that are effective against influenza strains, even though influenza strains we don't know about. We don't have either for coronavirus. We don't have antivirals, and we have never made a vaccine against any coronavirus. Never made a vaccine against the human coronaviruses that are pretty mild. We didn't successfully make a vaccine against SARS. We didn't make a vaccine against MERS, which are the other coronaviruses. So we don't have a template. We don't have a pipeline for that. So it's an unknown at the moment. Now, that sounds bad, but, there are so many, the best research groups around the world are trying to solve this problem. And, this is an unprecedented situation. And, the efforts put into this, by dozens of research groups around the world, I am optimistic that we will be able to make one, because the value of such would be high, and the need for it is so clear. I mean, this must be the priority, to generate a vaccine. How long that takes, given that we have never made a coronavirus vaccine, is unknown. The best case scenario is 12 to 18 months is the figure that's bandied about. But vaccine. We have never made a vaccine against HIV. We have never made a vaccine against. It took us 10 years for Ebola virus. We've never made a vaccine against herpes virus. There's lots of viruses we've never made vaccines against. So there could be. We could see stuff that works in animal studies and then just doesn't work in humans. We could see stuff that has side effects in humans. This is a vaccine you want to give to billions of people who are healthy. So a rate at which it causes serious side effects in 1 in a million people, or 1 in 100,000 people, is not appropriate. You can't give something which has serious side effects at a low frequency.
Yeah, we hit the ethical part of the research where, like, Dr. Hugo Strange from Gotham would not care about, but we have to.
Yeah, absolutely. It has to be absolutely safe before we roll out. Now, that's very different from an antiviral. Yeah. You can use an antiviral for someone who's, has a 50% chance of dying from pneumonia. You're prepared to risk a few side effects.
There is something about this virus which is really freaking me out, and is the fact that at the last stage, people that die, they do not die because of the virus, but actually they're dying because the virus gets into the immune system, make it crazy, and then there is
we call this a cytokine storm. Basically, your immune system overreacts, and this is not just coronavirus. This is quite a few different viruses.
Hepatitis V.
The immune system overreacts, and it's the damage that the immune system does which kills you.
Yeah, hepatitis C does the same. Because I have a direct experience with my grandmother, which had this problem happening. Yeah.
It is terrifying.
Yeah, it is. That's why a lot of drugs that are actually immunosuppressant. I read have been effective on keeping the patient alive, at least, even if they are very sensitive to new infection or bacterial infection and fungus. After that.
And conversely, there's drugs which reduce viral load, which don't alleviate the symptoms. So you can find drugs. I mean, that's why you have to be careful about the drugs you use. You can say, this kills the virus, it's fantastic. And then you see that it actually doesn't mitigate the effects of the cytokine storms. So it's useless.
Yes.
So, Tim, on that note as well of the virus, obviously I suppose the order would be firstly to see how the body itself reacts to this virus and how the immune system responds and whether we can be infected again before we go ahead and try to make any vaccine for it as well. Is that correct?
No, because even if the virus doesn't induce good immunity, I said it doesn't bode well for a vaccine, but it's not a deal breaker.
Okay.
So we should be trying to make vaccines now.
Okay.
There's no risk, and there's different strategies. You can try to make a weakened version of the virus. You can try and just grow it up and then kill it, and that's what we call a dead vaccine.
Yeah, just the shell goes in the bloodstream so that the system can recognize the structure of what covers the virus.
Exactly. So the influenza jab, that's a dead virus. But it's still
no RNA inside.
So it still looks like a virus, and the immune system will recognize it and make antibodies. But then there's living viruses which are attenuated, which are weakened, and they multiply, but they don't cause symptomatic disease. So that would be, for example, the measles, mumps, rubella vaccine. Yeah.
So, Tim, now the question and the concerns that we have at the moment, right, is that should have we locked down Australia 2 weeks ago? Or should we have a complete lockdown now? Like, forgetting about the economical consequences, like the financial, etc., would have made sense, right, to lock Australia completely, so that we would have avoid the risk of getting of overloading our healthcare system eventually. Would that make sense?
I know this is the question which I really struggle to answer, because one, it's slightly out of my field. I'm not an epidemiologist, so I don't model disease spread, and I think any answer is going to be true or false in retrospect. If the measures we used managed to reduce spread sufficiently to allow us to appropriately care for those who need it, then we were successful. If not, then we weren't successful. I think the messaging by the Prime Minister has been a little bit confused. I'm troubled by the fact that he was so critical when advice wasn't followed and everybody partied on Bondi Beach, and then the next time you hear him say, well, these are the rules, but there's also all this advice which I trust Australians will follow. Well, we didn't last time. And then we screwed up with the cruise ship. So,
that was completely ridiculous. So
are we past the tipping point already? I know behind the scenes that New South Wales Health and presumably all of Australia are trying to collect their resources, prepare as many beds as they can, a number of respirators, diagnostic equipment. They're sourcing this from wherever they can find it, so they're trying. I would say that I'm very alarmed by the increase in number of cases, and you're not going to see effects on the increase in number of cases for at least 2 weeks.
Yeah.
You're not going to see effects on severe disease and deaths for maybe a month. So if we see the severe cases and deaths are out of control, it's measures you've done a month ago that are going to start paying off. So that's a huge delay.
Yeah. So this is I follow Dr. John Campbell from UK. He's a big fan of proactive actions against reactive, because we know exactly how the disease is growing, which is an exponential growth.
And every case we know about, there's 3 or 4 cases we don't.
Yeah,
clearly.
Especially with Australia's testing system, that we're not testing everybody with symptoms. We're only testing people with symptoms that have been in contact with someone that's tested positive or have recently been overseas. So there's also a chance that we're ignoring a lot of positive cases as well. Is that right?
Yeah, I know. And we're seeing now that, I think it's going to be days before community transmission is going to outnumber imported cases. It's pretty much 50-50 in, I think, New South Wales. Once you have ongoing community transmission, then, it doesn't matter how many planes or cruise ships you turn away, right? It's social measures which are going to do it. Now, with respect to the kits, I think this is the same question with respect to the masks. These are in finite supply. So every kit has to be used most efficiently. Every mask has to block as many transmission events as possible, right? So that's why healthy people walking around with masks, when people are not getting surgery because surgeons don't have enough PPE, is frankly ridiculous.
Yeah.
The mask should be available to healthcare workers and people who are sick. Once we've completely fulfilled that need, then you can get people walking around the streets in masks. But, if you're walking around the street and you're sick, you shouldn't be. And if you're walking around the street and you're healthy, you shouldn't be wearing a mask until that supply is no longer a rate-limiting step.
So what you're saying is that it's not that the masks won't help, it's that it's more important in our health system to make sure that the people that are on the front line have access to this PPE rather than us using it on the streets.
Yeah, rather than someone that could have been sick, right? Maybe it would be good to have him, but anyway, it would be a priority to give these people this PPE to the personnel is curing people who are heavily sick.
Yeah, that's part of the answer. We need to keep our healthcare workers, safe. Otherwise, they won't be able to treat you when you're sick.
That's correct. That's correct.
And I think the other addition to that is that I see people wearing the masks. They're wearing, one mask the whole day. They're touching it with their hands. They're putting it on their chin
because there is a complete.
They're not well fitted, so they're not doing anything anyway.
That's correct. There's a lot of not understanding of the purpose of that PPE is.
Exactly.
So what blows my mind is the fact that. So I have 2 cases. So one is Italian and one is the South Korea. So there is a city in Veneto in Italy. Basically, as soon as there was the rumor that the disease was spreading, they closed down this village. They tested everyone. everyone.
Yeah, there were 3,000 people, right?
Yeah.
Is that right?
Yeah. And basically there are no more cases, further cases. So the complete lockdown, there are no more cases. So the people that got sick have been treated. There is no community spread. And in South Korea, right, they've been doing drive-through testing post, where you basically, it's like a McDonald's. You go there, personnel just wipes you, gets the sample and gives you a code, and then after a few hours you check on the website if you're sick or not, and you stay home. So my question is, with all the billions of taxpayers that we have in Australia, right, would have made sense to go straight away on that direction and prevent this? So there was like a little bit maybe of naiveness from the people advising politician on, or the advice that was given to the politician wasn't right. Because what I think is that if you would get at least the capital cities, CBDs, to have this such, like all the people that commute very often to get tested just after they jump off the train, and then because that's what's happening, is that what I see is much more I think most of the spread happened in these hubs where people gather together, airports, train stations. So
look, I think the rates until, well, even maybe now, are so low in the community that I'm not sure widespread testing is really worthwhile. Certainly, I would agree with you, without a doubt, that more testing would be great. Probably, if we had been last month testing every single arrival into Australia, that could have been probably more efficient. But from what I understand is that it's also the lack of reagents and capacity. So I don't think we could do all that testing. I mean, the reagents for the tests are in short supply. So I think it is a matter of doing what we can with what we've got. Now, hopefully that will be less of a rate limiting step or less of a bottleneck in the future. And then maybe we can change the strategy. Maybe it'll be too late then. But up until fairly recently, you were still in the hundreds of cases. I mean, you're not going to test, 20 million people, effectively. That kind of capacity is just, we can't. We just have to.
For the most part, I think, Tim, what we need to gather from this is that the mentality that I suppose a lot of fellow Australians have, that it's not going to affect them, it's not going to be an issue for them, we're going to have the vaccine before it gets here. These aren't things that are actually going to delay or spread this virus. What's actually going to matter is that social distancing, not to go outside if you don't have to, and to stay inside for as long as possible unless you're desperate.
And I expect those measures are going to become stricter. I mean, in Germany, I think now you're just not allowed to be in a group of more than 2 people. I think in Spain and France, it's even, you just don't leave your house. In Greece now, you need to text permission to leave your house, I think, to go and get shopping and stuff like that. So, so what we're doing is social distancing now, and again, is the very poor messaging about an essential job. Oh, everybody's job is essential. It is
I heard that.
very confusing for people. I guess I am concerned about this idea that you just control the spread and the problem's solved, because if you do that, you've still got a population who are completely naive and susceptible. So, is that just, do you just isolate this town or city or country forever? I mean, it's out there. It's not going to go away, So it just seems that, the choice is either to completely change how we interact in societies, or just wait until we've got a vaccine, which, can we function as a world into lockdown for 18 months, 2 years, 3 years? I mean, we can't, so I think it's great, that we've seen this effectiveness in like this Italian city and South Korea, but what happens after that?
So it's more of a short-term strategy. It's more of a way to allow us to slow this virus down until we have a long-term solution, rather than...
where that long-term solution is still a question mark.
Yeah, okay.
Well, it's important either way to flatten the famous curve, right, of people that get sick.
Yeah, well, I know. I mean,
Yeah.
as I said, I'm not an epidemiologist, but I mean, I think that if we just keep the levels that we give everybody who's sick a chance of survival, yeah, I mean, there's going to be a huge loss of life, whatever happens.
Yeah. All right, so I guess that was a very good talk. Thank you very much.
Yeah. Okay. Good. I'm not an expert on medical or virology or epidemiology or modelling, but hopefully, I've had some good questions.
Yeah, well, this virus is mysterious in nature, being novel coronavirus, SARS-CoV-2, big names and very scary ones. So we kind of had the need to not just source information from that newspaper or that expert that is tweeting something. We wanted to touch someone from Sydney, like you are a Sydneyist, so and researcher, and we want to listen what the our local expert have to say about this.
Yeah, well, thank you. And if you've got any more questions, just email them to me, and I can write you something in response, or if you want any references or something. You said you wanted the. I'll text you that 80% or more social distancing is needed to flatten the curve.
Yes,
that's by Mikhail Provchenko or something like that. And that was a news release by the university, so it's quite an interesting study.
Yeah,
awesome.
Sure.
We'll be happy to post that as one of the articles as well on our app. But
I might have to just send you a screenshot. You might have to chase it up from that information.
That's okay.
Yeah. No worries.
Okay, good.
All right. Thank you so much for that, Tim. I really appreciate it.
Have a good night.
Yeah, cheers. No, you too. Bye.
Bye.